Welcome to the deep dive.
Okay, let's unpack this. We're diving into a topic today that, well, it really touches everyone, doesn't it? Patient safety in healthcare.
It really does.
Yeah, and there's this widespread feeling, backed up by reports, that healthcare systems need some fundamental changes
Hmm.
to really improve how patients are cared for. I mean, we're talking about potentially thousands of deaths each year linked to errors. It's a sobering thought.
It is a stark reality, but also, like you said, a huge motivator for change.
Absolutely. So our mission here in this deep dive is to give you a shortcut, really, to understanding a pretty groundbreaking methodology, something practical, designed to make healthcare demonstrably safer.
And what's fascinating here is, well, for a long time, a major barrier to actually making progress in safety was the difficulty in measuring harm,
Yeah,
effectively and consistently.
right. How do you fix what you can't properly measure? Exactly. Traditional methods just fell short. They made it incredibly hard to pinpoint where the real problems were. So we're going to introduce you today to an innovative method called the trigger tool.
Trigger tool. Okay.
Yeah, it's an approach that allows for much more consistent and accurate measurement of harm. So we'll dig into its history, how it's used in different ways, and the kind of impact it's starting to have.
Okay. So early on, safety efforts, they tended to focus a lot on identifying errors, right?
Well,
Counting mistakes.
that's right. Identifying and quantifying errors.
But as our source material points out pretty clearly, that didn't always lead to the safest outcomes, which kind of makes you stop and think, why wouldn't focusing on errors be the best way to improve safety? Here's where it gets really interesting.
Well, that's a really critical distinction we need to make. And the sources we looked at laid out very clearly. It's the difference between errors and adverse events.
Okay, errors versus adverse events.
Yeah. So medical errors are basically failures in the process of care, a mistake in how things are done. Now, they definitely have the potential to be harmful,
Yeah.
but report after report shows they often aren't actually linked to patient injury. Think about giving a drug an hour late. That's an error.
Right.
Or even giving the wrong drug, say a small dose of Benadryl diphenhydramine, to the wrong patient. It's an error, yes, but often there's no significant damage. Maybe it gets caught, maybe the drug itself is pretty benign in that context.
Ah, okay. So an error is about the process messing up, but the patient isn't necessarily worse off.
Exactly right. Now contrast that with adverse events. These are directly linked to actual harm. Real injury resulting from medical management.
Hmm.
It's caused by the care itself, not the patient's underlying condition.
Okay, so that's actual harm.
Yes, and here's the really crucial bit. An adverse event can happen even if the care was correct, even if no error occurred. Well, imagine an invasive diagnostic test. It's done for the right reasons, the right indication, and it even successfully gives the diagnosis needed. But an unforeseen complication happens anyway, maybe an infection or bleeding from the test site.
Ah, I see. So the procedure was right, but something bad still happened as a result of it.
Exactly. No error was made in performing the test. The decision was sound, but harm still occurred.
Wow, okay. That distinction, it just fundamentally reframes how you'd approach safety, doesn't it?
It absolutely does.
So focusing only on errors might mean you're missing a whole chunk of the picture where patients are actually getting hurt.
Precisely. If we connect this to the bigger picture, it really changes how we approach improvement. Just looking at errors might not link a mistake to actual human harm, and it might not uncover those deeper systemic issues that lead to injury.
And thinking about it from the patient side,
Yeah.
they might not know or care if a specific error happened. The process details aren't their focus, but they definitely know if they were harmed. And our sources do clarify, for this methodology, they limit harm mainly to physical injury. It gives a clear, definable starting point for organization.
A practical base to work from.
Exactly. So shifting the focus, moving from errors to harm, what are the advantages there? Seems like a big one is targeting the system.
That's a huge advantage. When you focus on harm, you naturally start looking at the system of care, not just blaming individuals.
Right, which must help with getting people on board.
It fosters much greater compliance, definitely. It reduces those punitive concerns, that fear factor that can make staff hesitant to report problems in the first place.
Yeah, I can see that. There's a really powerful line in our source material about this. A system is designed to deliver the exact results it delivers.
That sums it up well.
And if you take that view, looking at harm redirects your effort. You're trying to fix the operational system, the process itself, rather than just pointing fingers. It becomes about continuous improvement.
And this strategic shift was really necessary because, as I mentioned, the conventional ways of measuring harm just weren't cutting it. They had significant flaws.
Like what were the old methods?
Well, take incident reports. The form staff fill out when something goes wrong. Historically, they've been massively underutilized, just not used enough.
Why is that? Just too busy?
That's part of it, sure. Workplace pressures, time constraints in busy environments. But maybe even more powerful is the perception of punitive consequences.
Ah, the fear factor again?
Yeah, nurses, other staff, they worry it could impact their careers or their colleagues' careers. So things just don't get reported as often as they should.
Okay, so incident reports are unreliable. What else?
Then you had chart reviews, either looking back retrospectively or trying to do it concurrently as care happens.
That sounds thorough, at least.
It sounds thorough, but it's incredibly time-consuming and often inaccurate. You get huge variability between reviewers.
Different people see different things or classify them differently.
Exactly. There's often no consistent way of defining or classifying events. Plus, extracting meaningful data from medical records. Well, records can be poor, incomplete, even conflicting sometimes. And it costs a lot, both in time and money. Highly resource intensive.
Okay, so time-consuming, expensive, and potentially inaccurate. Not ideal.
Not ideal at all. And finally, you had attempts using observational data. But that was also pretty ineffective, mainly because, historically, there just wasn't a clear consensus on what harm actually was. The kind of distinctions we just talked about between errors and adverse events weren't always applied consistently.
So all these traditional methods had major drawbacks.
They did, which raises that key question. If those methods don't work well, how can we reliably identify and measure actual patient harm? How do we get the data we need to drive real safety improvements?
And that, I assume, is where the trigger tool comes in.
That's the innovative answer, yes.
Okay, let's unpack this then. The trigger tool. You said the idea isn't brand new.
Right, the basic concept of using a trigger or a sentinel word in medical record to flag potential adverse events, that actually dates back to 1974.
Wow, okay.
But it was later refined and, importantly, adapted for use with electronic systems that help make it more practical for isolating these events.
So how does it work? What's the core mechanic?
It's actually quite elegant, really.
Yeah.
Certain specific events recorded in the medical record, these are the triggers. They act like signals or sentinels.
Okay.
When one of these triggers is found, it initiates a closer look, a more detailed chart audit. These triggers could be things like ordering specific drugs, like an antidote.
Ah, like if you suddenly need Narcan.
Exactly. Or orders for antidotes, certain abnormal lab results, maybe an abrupt order to stop a medication.
Yeah.
Each time a trigger is spotted, it gets counted, referenced, and prompts that deeper review.
So the trigger itself isn't automatically proof of an adverse event. It's more like a flag.
Precisely. That's a great way to put it. It's a red flag pointing toward a potential adverse event. The key idea, the hypothesis behind trigger tools, is that monitoring these specific events tightly linked to harm, gives us a much more powerful way to reduce injury.
Because you're focusing effort where harm is most likely.
Right. You focus on identifying and documenting adverse events that have a higher net yield, as the source puts it. Because harm is the focus, not every little error, many of which might be benign.
That makes a lot of sense. You're hunting for the consequences, the things that actually hurt patients, not just process glitches.
Exactly. And the ultimate goal is to use that information, the documented adverse events, to develop targeted interventions, fixes that combat the systems that lead to poor outcomes or injuries. It's about finding the root cause of the harm.
What really strikes me is how adaptable you said these tools are. They're not just one thing, they can be tailored.
Oh, absolutely. They're not one size fits all. The source material details 4 different functional trigger tools that were developed and tested in various settings.
Okay, let's hear about them.
Sure. First, there's the General Adverse Drug Event Trigger Tool, often called the ADE trigger tool. This one was developed by the IHI, the Institute for Healthcare Improvement, and Premier.
Big names in healthcare quality.
Right. And it's used by over 200 organizations now. It has 24 triggers, and reviewing an average inpatient chart takes about 20 minutes.
20 minutes, that's pretty quick. What are some examples of triggers?
Things like the use of Narcan, like we mentioned, or maybe rising serum creatinine, which indicates kidney problems often linked to drugs, or even the use of diphenhydramine Benadryl.
Ah, but you mentioned Benadryl earlier as an example of something that might be an error but not harm.
Exactly, and that highlights a key nuance. Not every positive trigger means an ADE happened. So if diphenhydramine is used as a routine sedative, that's not an ADE trigger hit.
Hmm.
But if it's used to treat an allergic reaction to another drug, that is.
Got it. So the trigger prompts a quick look at the chart to see the context.
Precisely. A quick chart review clarifies it. This general tool is great for tracking an organization's overall harm burden from medications over time. The U.S. hospital baseline rate is around 2.64 ADEs per 1,000 doses administered, or about 24% of all admissions experiencing one. And crucially, it's easy to learn. Training takes about 30 minutes.
Wow, 24% of admissions. That's significant. Okay, what about more specialized areas, like the ICU?
Good question. That leads to the second tool, the ICU adverse event tool. This one also has 24 triggers, but it's designed to capture all types of adverse events in the intensive care unit, not just drug-related ones.
Okay, a broader net for a high-risk area.
Right. It's typically used with smaller samples, maybe reviewing about 10 charts every couple of weeks. But the impact is telling. It detected an adverse event rate of about 0.164 per patient day and found that 55% of ICU admissions experienced at least one adverse event.
55%, that's huge. What kind of triggers are common there?
Things like intubation or needing reintubation, oversedation, or a significant drop in hemoglobin, say more than 4 points, which suggests bleeding.
And again, context matters. Like, intubation might be planned.
Exactly. Intubation is often anticipated in the ICU, but the chart audit prompted by the trigger helps determine if it was truly an AE, maybe due to unexpected deterioration or some aspect of avoidable care management. Other ICU triggers mentioned include positive blood cultures, suggesting hospital-acquired infections or very low blood sugar, possibly from insulin issues, or those rising kidney function markers like BUN and creatinine.
So it's really about using specific clinical flags that strongly suggest something went wrong, then confirming with a quick review.
You've got it. That's the core principle. Third, we have process-specific tools. These zoom in on a particular process known to be high risk. The example given is a warfarin trigger tool.
Ah, anticoagulants. Always a focus for safety.
Definitely. Warfarin use is a common source of ADEs. So this tool uses triggers like really abnormal INR results of blood clotting tests, say an INR over 6, which is dangerously high, or below 1.5 when anticoagulation is needed, or triggers like clinical signs of bleeding or finding progressive anemia in the patient.
So it helps monitor that specific high-risk therapy.
Yes. It focuses tightly on the outcomes related to warfarin safety.
Hmm.
It lets you measure the harm burden from that specific drug, and really importantly, lets you quantify if changes like implementing standardized dosing protocols are actually working to reduce harm.
Makes sense. Measure the impact of your improvements. Okay, what about outside the hospital walls?
Good point. There's also an outpatient or ambulatory care setting tool. This one gets customized using what they call life events.
Life events? Like what?
Things like a visit to the emergency department, maybe a new cancer diagnosis showing up, or certain abnormal lab results coming back. So for instance, if a patient ends up in the ED because of a bad reaction to a medication they take at home.
That ED visit is the life event trigger.
Exactly. It flags the record for a review.
Yeah.
And this approach can be incredibly efficient. One organization reviewed 200 care years of patient data in less than 4 hours using this method.
Wow, 200 carriers in under 4 hours. That's impressive speed.
It is. And they found an adverse event rate of about 17% per year for older patients, over 60, who had at least 2 outpatient visits.
That's really significant for outpatient care. So these tools, they're incredibly versatile. You can really tailor the approach to get to the heart of where harm is actually happening in different environments.
That's the beauty of it. And if we connect this back to the bigger picture, the main goal of these trigger tools isn't just measurement for measurement's sake. It's to provide a process, a mechanism for organizations to directly intervene and improve the system of care.
Right.
It's about building that measurement infrastructure, using data to make medical environments safer. It enables that data-driven action we talked about, moving beyond just reacting to individual incidents.
And the practical upsides seem pretty clear, too. You mentioned it's economical.
Yes, it can be started manually, very low tech, doesn't need a huge capital investment up front, though it can be automated later.
And flexible, customizable.
Right, easily refined for specific areas like ICUs or even, say, cardiac cath labs. And it's proven to be accurate and efficient. You can get reliable quantification with relatively small sample sizes, and it allows for tracking changes over time, longitudinally.
And you mentioned something about the manual approach connecting people.
Yeah, that's a nice side benefit of starting manually. The reviewers, often nurses or pharmacists, are directly connected to the system users on the front lines. So the improvements they suggest tend to be highly relevant and practical.
That makes sense. What about results? Have organizations seen real improvements using this?
Oh, yes. The results can be quite dramatic. Several organizations that adopted the trigger tool methodology reported reducing their adverse drug events, those ADEs, by more than 50% in just 6 months.
50% in 6 months, that's huge.
It really is. And remember, ADEs are still the single biggest recurring source of incidents that put patients at risk, just because medications are so widely used.
Now, it seems important to stress one point, though. The trigger tool itself, it isn't the fix, right? It's not an improvement methodology on its own.
That's a crucial clarification, absolutely. The tool is an instrument. It enables data acquisition. The subsequent analysis helps you identify where the harm is happening and figure out where improvement resources need to go.
So it guides the improvement work.
Exactly. It's all geared towards producing a safer medical environment, not just generating numbers or engaging in measurement activity for its own sake.
Okay. So, bringing this all together, what does this mean for you listening? I think this deep dive has really shown us a compelling shift, hasn't it? How healthcare is thinking about patient safety, moving away from just reacting to errors.
And towards proactively focusing on and measuring actual harm.
Yeah, a proactive, harm-focused strategy.
And the key takeaways on the trigger tool itself. We've seen it's relatively simple, it's consistently accurate, it's flexible across all sorts of clinical settings, and it's cost-effective.
Fundamentally, it gives a reliable way to measure patient injury.
Which is what you need to drive real, lasting improvement in safety.
So here's a final thought to leave you with. Consider how this shift, moving from just counting errors to actively detecting and quantifying harm, how that might change the way we approach safety and improvement in any complex system, not just healthcare.
Interesting point.
What hidden harms, what negative outcomes might we uncover in other fields if we focused intensely on the actual results, the real impact, rather than just looking for deviations from the planned process?
It makes you think about the power of precise measurement.
It really does. The power of measuring the right thing to drive systemic positive change, something to reflect on.